Hi, I'm Michelle Kittleson, Professor of Medicine at the Smith Heart Institute, Cedars-Sinai in Los Angeles, and Associate Editor for Jacc. I'm delighted to be joined today by Dr. Milind Desai to discuss three important HCM studies, two analyses of the Odyssey HCM trial, and one observational analysis. All three will be presented at the European Society of Cardiology meeting, and we are delighted to have these simultaneous publications in Jacc. Dr. Desai needs no introduction, but I'll introduce him anyway. He is Vice Chair of Education and CME at the Miller Family Heart, Vascular, and Thoracic Institute at Cleveland Clinic and Director of Clinical Operations in the Department of Cardiovascular Medicine. He is the co-director of the Cardiovascular Imaging Laboratories, Director of the Center for Hypertrophic Cardiomyopathy, and Medical Director of the Center for Aortic Diseases. He is Professor of Medicine at the Cleveland Clinic Lerner College of Medicine and holds the Haslam Family Endowed Chair in Cardiovascular Medicine. So clearly, he is the best expert to discuss these studies. So let's talk about the trial. The Odyssey HCM trial is a randomized controlled trial of mavacamten versus placebo in patients with non-obstructive HCM. We all know that cardiac myosin inhibitors improve feel and function in individuals with obstructive HCM. Non-obstructive HCM remains the great white whale. And based on the results of Odyssey HCM, it remains so. Mavacamten did not meet its dual primary endpoints of a change in the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score and peak oxygen consumption compared with placebo at 48 weeks of follow-up. However, that doesn't mean there aren't insights to be gleaned from this trial. We'll do two rapid-fire questions on the two important sub-studies published in Jacc, spearheaded by Dr. Desai, one on echocardiographic parameters and the other on biomarkers. So first question, Dr. Desai, tell us, what do we need to know about the effect of mavacamten on echocardiographic parameters in non-obstructive HCM?
Thank you, Michelle. Thank you for giving me the opportunity and publishing our paper simultaneously. So as you have very nicely summarized, in Odyssey HCM did not meet its primary, did not demonstrate statistical significance in its primary endpoints of KCCQ and peak VO2. But we also wanted to see if there is any signal, any directional changes, directional improvements noted on diastolic function, etc. And indeed, compared to placebo, mavacamten did demonstrate a significant improvement or significant directional improvement in diastolic function, in maximum wall thickness, in a subgroup without ejection fraction drop. So the ones that respond, there was also directional improvements in left ventricular global longitudinal strain, multiple parameters of left atrial function via strain, they also significantly improved. Of course, we have to put everything in the context of the clinical trial, and there were also patients who had LV ejection fraction reduction less than 50%, significantly higher proportion in the mavacamten group compared to placebo group. But this was a temporary reduction in EF, and pretty much everybody got their ejection fractions back to baseline once mavacamten was interrupted. So I think that's the big summary. There is some favorable impact on the pathobiology of HCM, but the improvements or the directional improvements that we see in that, they did not elevate to the level of having statistically significant improvements in, like you described, feel and function.
Amazing. Such a beautiful summary to help us really understand that just because a trial is negative does not mean you cannot gain insights that may inform future endeavors, which leads us to my second question. Tell us what we need to know about the effect of mavacamten on biomarkers in non-obstructive HCM.
So to again, continue the theme of pathobiology, what we found, again, at week 48 compared to baseline, there was a 58% reduction in NT-proBNP and 51% reduction in troponin I, similar findings in troponin T, whereas in placebo, there was no essentially no change. So there is something happening at a sarcomeric level. Again, I reiterate, it did not reach the clinical statistical significance for the clinical endpoint. So the other important thing we learned there is patients with the lowest amount of LV ejection fraction reduction had the highest biomarker reductions, improvement. So there was that inverse correlation, for the lack of a better term. And the other thing, the atrial, as you are well aware, there's a lot of hype and discussion around atrial tachyarrhythmias. And there, in the Odyssey trial, we did not find that atrial tachyarrhythmias played too much of a had too much of a major difference between placebo as well as a mavacamten group. So, we are learning. Again, I go back to, look, these are the clinical endpoints that we picked. So we gotta live and die by the endpoints that we have picked. But it also questions, should we have a, and should we have a, is there a subgroup that may respond more favorably than others? Clearly, we will be doing some additional responder analysis to understand that. The other question is, should we have the same clinical trial endpoints that we have with obstructive HCM as with non-obstructive HCM? Fully understanding that for Odyssey, this was what we picked, and we are going to live by what we have picked. So I think these are some of the things we need to understand.
Very well put from outstanding, reliable clinical trialist like yourself with tons of integrity. No one would be unhappy if their own NT-proBNP and high-sensitivity troponin went down. Those are all good things. And like you said, cause for optimism for future endeavors. So now let's switch gears. You have another important analysis that will be simultaneously published in Jacc with the ESC meeting, focusing on obstructive versus non-obstructive HCM, a report of the characteristics and long-term outcomes from over 3,000 patients cared for at your center between 2002 and 2021 with HCM deemed asymptomatic at baseline. Tell us what you found.
I think this is an important project. Obviously, we are a large volume center. And, as the mindset is shifting in every disease within cardiology, aortic stenosis, mitral valve, HCM, we need to shift the narrative leftward. Leftward, meaning towards a more asymptomatic or lesser symptomatic state. So we have been interested and we wanted to take a look at it. The challenge, as you can imagine, in a large tertiary care center would be how truly asymptomatic they are. Are they asymptomatic because they're on medication? Or so the toughest part of our job was when we did the first electronic health record pull, you get a certain amount of patients that I had my team look at every chart, every care everywhere, outside chart, inside chart, to ascertain and re-ascertain that they were indeed NYHA class 1. So the number we have, we are very comfortable that they were asymptomatic when we first saw them. And so this is more than 3,300 patients. What we found was, at least at face value, about 60% had non-obstructive, and 40% had obstructive. So again, in literature, we are talking about 60-70% have obstructive HCM. So if you don't look for carefully, or maybe in the asymptomatic group, this was the breakdown that we had. Folks that were obstructive were older, more likely to be women. Otherwise, a lot of these characteristics were similar. Importantly, again, I go back to atrial fibrillation. Almost 20%, 1 in 5 at baseline had atrial fibrillation. So AFib, the cause and effect with HCM, it's still that chicken and the egg situation with AFib. Be it as it may, at almost 10 mean follow-up of 10 years, a little over 10 years, about 75% still remain NYHA1. And the rest of them progressed to a disease state. And 11% of the population ended up having surgical myectomy. What we showed was, on a survival analysis, the folks who had obstructive HCM, did significantly worse compared to the non-obstructive HCM, whose outcomes were similar to an age and gender matched population. So I think this is important because we have bona fide therapies that work, class 1 indication approved. So we should be doing, I think the biggest message I learned from here is we should be doing more to truly ascertain asymptomatic status. And once we have done that, then truly ascertain that they also are not characterized as wrongly as non-obstructive when they should be characterized. We got to do all things necessary, including provocative maneuvers, as well as stress testing, et cetera, to elicit outflow tract obstruction.
I love that. And I think it really highlights for clinicians who have a patient sitting in front of them, what do you need to know to best care for the patient? What does the patient best need to know to understand the natural history of their condition? So we congratulate you on taking the time and trouble. Nothing worth doing is ever easy, but taking the time and trouble to painstakingly go through these 3,300 charts to figure out how best to phenotype these patients.
And the standard line I give my patients is as follows. Your history or you telling me you are asymptomatic is a starting point for negotiation. You're going to have to prove it to me either by provocative echo and or by stress echo. So I think it's important for us to be fully aware of that at all times.
Amazing. Well, that was an amazing whirlwind tour of HCM with a true expert in the field. Be sure to check out these papers in Jacc and also the editor's note in Jacc, authored by the amazing Harlan Krumholtz and yours truly, to put these important observations and their implications in perspective for clinicians, researchers, and individuals living with HCM. Dr. Desai, what a privilege. Thank you so much for joining us.
Thank you very much for having me here.